Hi, I'm Anthony Clough, one of two surgeons at Northeastern Weight Loss Surgery. I'm going to talk to you today about the obesity epidemic and the role of weight loss surgery, what can be achieved, what can't be achieved, and some of the metabolic benefits that some patients gain out of this kind of surgery. At Northeastern Weight Loss Surgery, it consists of myself, Mr. Patrick Moore, Meryl Bone, our clinical dietitian, and Christine Malone, our practice manager. So to understand obesity, it's useful to understand the term body mass index. This takes one's height into consideration when trying to decide how overweight a particular person may be, or how that overweight or obesity may affect them metabolically. Body mass index is a way of taking your height into consideration when trying to decide about how overweight you are and what the medical effects of being the weight you are. Mass index is calculated by taking your weight in kilograms and dividing by the square of your height. You can see in this chart the different ways that we fall into body mass index. The best and most healthiest place to be is somewhere between 18.5 and 25 with body mass index. In Australia today, and also in the United States and many other Western countries, the majority of people actually don't fall into this category. About 30% of people in the United States fall into the overweight category, that is BMI between 25 and 30, and another 30% fall into a category above. So body mass index is certainly useful in trying to give us an idea of how being overweight or obese affects our health, and this is so you can see here at the bottom of the graph the best place to be in terms of annual mortality risk is between 20 and 25. As soon as you start going above 25, your risk of dying from any cause starts to grow almost exponentially, and once you get up to the BMI 35-40, you can see that your body mass index is really conferring upon you a very significant metabolic risk. The question that everyone would like to know the answer to is, why has it happened? Why do we have an obesity epidemic in the year 2000 and in the late 1990s? The cause of obesity, I think most people agree that the cause of obesity is multifactorial. There's no doubt that genes are an important role in causing obesity. In this slide here, you can see a picture of two mice. The mouse on the left has an abnormal, what we call leptin gene, that is unable to produce the hormone leptin, which is an appetite suppressant. The mouse on the left, the mouse on the right, is able to do this normally. They've both been given the same amount of food, and yet one mouse has gained an enormous amount of weight. And this demonstrates quite clearly how genetics can play a part in the formation of obesity. Physiology and hormones, we know more and more about different hormones such as ghrelin, which are associated with obesity or are in the body to fight gain of weight. Behavioural programming, what was put on your dinner table when you were a child? How did your mother and father perceive food? Are you someone who was taught always to clear the dinner table before you left, always to clear your plate before you left the dinner table? These sort of behavioural programs are very strongly imprinted on our minds as we grow. Socioeconomic impacts, it's well known that people in lower socioeconomic groups tend to be bigger, not by a great deal, but by a small amount than people in higher socioeconomic groups. Psychosocial effects, coping mechanisms, comfort eating, and of course the role that our society plays. In modern society in the Western world, there are so many ways to avoid getting exercise. Production lines are often automated at work, in workplaces. We have elevators instead of stairs. We drive cars instead of walk or ride to work. These days, the need to exercise must be a proactive thing that we tell ourselves to get out of the house and exercise, rather than something that we have to do. So our exercise levels are much less than they used to be. You only have to have a BMI of 30 for you to have a 60 times increased risk of developing type 2 diabetes. It is strongly associated with weight. Sleep apnea, cardiovascular disease, high blood pressure, osteoarthritis, an increased risk of various cancers, and this is just a small sample of the various medical conditions which are associated with obesity. Sleep apnea is a condition whereby an overweight patient accumulates a lot of fatty tissue around the pharynx, and that can make it actually difficult to breathe at night. Patient falls asleep, the airways actually block off because of the fatty tissues. Patient has what we call an apnea, doesn't breathe for some time, perhaps even 20-30 seconds, wakes up with a gasp and hyperventilates, and the pattern repeats time and time again overnight. Patient wakes up in the morning and feels like they've hardly slept at all. Severe tiredness, falling asleep during the day, we call it hypersomnolence, and it's usually associated with heavy snoring at night. We know that being overweight and obese has a host of psychological and social impacts as far as self-esteem, getting a job, keeping a job, relationships, personal hygiene and sexuality. For many patients, dealing with these issues are just as important, sometimes more important, than the medical benefits from weight loss. So this leads me to talk about surgery, the rationale for surgery. How do we justify performing an operation under general anaesthetic, playing around with the stomach to try and make someone lose weight? This is a study that was done in Melbourne some years ago. It's a gastric banding study where they took a group of patients who were morbidly obese and gave them a medically supervised diet and exercise program, and then took the other group and gave them gastric banding surgery. You can see that both groups have lost weight at the 6-month mark. In fact, they're more or less the same. After 6 months, the curves separate. The bariatric surgery patients continue to lose weight and sustain their weight loss, and this can be seen out to many years. Whereas the patients in the diet program, unfortunately, most of them put their weight back on. This is another study, an older study using a different operation called a jejunal ileal bypass, but it essentially shows the same thing, the difference in the curves between the surgical patients who are morbidly obese and the patients undergoing a supervised diet and exercise program. The best study ever done on obesity and obesity surgery was, in my opinion, the Swedish obese subject study. This began in 1987, where they took about 2,000 morbidly obese patients and subjected them to bariatric surgery, and 2,000 morbidly obese patients who underwent diet programs. What they found after 11 years is that the weight loss surgery group had kept off 20 kilograms of weight loss on average, whereas the group who hadn't undergone surgery had actually gained weight up to 1.3 kilograms. Certainly it's true to say that bariatric surgery is extremely effective to resolve type 2 diabetes. It does depend on what operation you have, and it does depend on how successful you are. In 2009, there was published a meta-analysis, which is a review of many different trials. A total of 8,000 patients approximately who were diabetic were studied who underwent obesity surgery. Out of those 8,000 patients, about 78% had complete resolution of their diabetes, and 86% had significant improvement or resolution of their diabetes, leaving only a very small percentage who didn't have significant gains in terms of their diabetes from the weight loss surgery. Most of the operations done in this review were gastric bypass surgery, which is well known to be a very effective weapon against type 2 diabetes. What they're looking at here is the AHI measurement, the apnea-hypopnea index, which is simply a way of trying to quantify how bad someone's sleep apnea is. You can see the average AHI measurements on the top half of the figure, and on the bottom half of the figure you can see that they've all moved to the left of the page. And this indicates the changes from obese patients before the surgery compared to after the surgery, indicating huge gains in terms of sleep apnea management. We all want to know, if I lose weight with weight loss surgery, am I going to live longer? Does it increase my lifespan? No one really definitively knows the answer to this question, but there's certainly been a few studies that suggest that it is indeed the case. And back to the Swedish obese study, a Swedish obese subject study, you can see here the bottom line represents surgical patients, morbidly obese patients who've had weight loss surgery, and the top line represents those who haven't in the morbidly obese group. And what they're measuring is mortality, that is the percentage of people who have died from any cause after a certain period of time. Here we can see at about 8 to 10 years the curves start to separate. And if you're lucky enough to have had surgery, by 12 to 14 years your chance of dying was about 6%, whereas if you hadn't had surgery you're getting up to almost 10%. So this probably represents the best evidence we've got that weight loss surgery almost certainly does extend lifespan in selected cases. Some other points of interest for weight loss surgery: we think that successful weight loss surgery will improve fertility if you're trying to start a family. It may reduce your incidence of certain cancers. It will probably improve your asthma and improve your self-esteem, quality of life and rates of depression. So that concludes my discussion regarding the rationale for obesity surgery and the effects of obesity on our metabolic health. Thank you very much for listening.